morning, good afternoon. My name is Dr. Sadimo Hasanelwe Habakore in the Ministry of Health and Wellness. I'm working with the Primary Healthcare Support Division, and I have compiled this presentation. The first few slides will be shared for you by our Early Childhood Development Focal Point, Mem Zanele Busa, who is retiring end of the month. So she'll be sharing with you the introductory slides, and I will conclude with the rest of the presentation. So over to you, Mem Busa.
Good morning, good afternoon. My name is Zanele Busa, as she has already mentioned. I'm going to be presenting on the background of hepatitis B in Botswana. First of all, I'll give you the statistics. We have 52,306 live deaths per year. And in hospital beds, we have 98%, which is 52,206 live deaths. And this is according to the National Statistics Office. Hepatitis B prevalence in an adult HIV center population was done in Gaborone, and it is 53%, according to Patel et al. Hepatitis B prevalence from research. There is no routine data for prevalence survey done at National Health Lab. And an estimated prevalence of hepatitis B is in the general population, it's only HIV positive population of 10.6, and this was done by Wester et al. In 2006. Estimated prevalence of hepatitis B among pregnant women is 2.1% in 2018, and this was done by Mbangiwa et al. And samples show 1.1% HIV negative and 3.1% HIV positive. Estimated prevalence of hepatitis B antigen among children below 5 years. Below 18 months, it's 0.67%. According to the draft publication of Botswana Harvard Partnership. And for BCG, BCG is also given at birth, and also we provide vitamin K at birth. In 2019, our coverage was 78% for hepatitis B3, and hepatitis B at birth was 73.8%, almost 74%. Hepatitis B screening and prevention policy. There is no policy on hepatitis B prevention of mother to child. There is no hepatitis B antigen screening during pregnancy. We only do it for syphilis, gonorrhea, HIV at first visit, second and third visit of antenatal care. Treatment guidelines for hepatitis B infected pregnant women have not been included in the current safe motherhood guidelines. the introduction and coverage improvements. The EPI program was established in 1979. And before then, the vaccination was done sporadically. And to those who knew about it or who thought they needed to be vaccinated or their kids to be vaccinated. A baseline survey was done in 1989 by the EPI program and some international partners, and the prevalence was at 12%. And therefore, it was suggestive that we should start the hepatitis B program. This includes hepatitis B as one of the vaccinations for under 5s. No evidence of NITAG involvement, but there was a recommendation, which I've already said, that they decided the EPI program, Botswana EPI program decided to start the program. And this was done in 1992, and in 1993, the piloting started. Program costs were covered by the government at 100%, and private sector gets free vaccines from government and charge for administration. Almost all the deliveries occur in the health facilities. Dr. Sadimo will continue with the presentation.
Thank you, Zanele Mabusang, for that excellent coverage of the background. I just wanted to highlight some of the challenges that we are experiencing with the hepatitis birth dose program and the immunizations in general. There's a problem with documentation for vaccination. And this is where you can see some of the discrepancies in the coverages, which is something that we're working on, strengthening our M&E systems and our surveillance systems, which is part of the restructuring processes to try and strengthen our health systems in country. We noticed when we did a birth dose assessment in 2016 that the premature and sick babies were offered the Hep B birth dose vaccine on discharge, and they're not given the vaccine and in the first day of life, in the first 24 hours. And we tried to increase awareness that the birth dose should be given in the first 24 hours. The opportunities for hepatitis B birth dose coverage improvement are many. We need to really strengthen collection of data on hepatitis B prevalence. Maybe start with our National Health Lab doing surveillance, and start with a policy maybe to institutionalize the surveillance for hepatitis B, especially at ANC and for triple elimination. We need to evaluate the general immunization program to see really what is causing this lag in coverage for immunization. What are the health systems challenges for Hep B birth dose and other immunization and other antigens that have low coverages? We know that there are a lot of health systems challenges. A lot of our mobiles are not being accessed, which usually outreach used to cover these mobiles when there was transport from local authorities. And because of these transport challenges, many of our mobile stops are not reaching out to cover the high coverages that Botswana used to experience many years ago. We would like to improve coordination and implementation of birth interventions at program and planning level, at the program level and at national level. Because if once we integrate and coordinate at planning level, it's easier for the programs and the districts to also integrate. And most importantly, we really need to resuscitate perinatal committees. In the earlier years, Botswana had very strong perinatal committees where the obstetricians and the pediatricians used to audit neonatal deaths, maternal deaths, perinatal deaths in the facilities. And we had strong district structures that used to investigate these cases and improve quality of care. So we would really like that revitalization of those primary healthcare structures that used to exist in former years. We would like to also include hepatitis screening for couples at ANC. We have a couple screening program, which is with the HIV program. But we would like to see this fully integrated into ANC, where we strengthen the surveillance for all the STIs, namely hepatitis, HIV, and syphilis. And we strengthen couple testing at the start, and even develop a prenatal service in the country if that is possible. We would like to train midwives on integrated EPI, MCH, and it also includes PMTCT, because they are currently working in silos. They have different budget lines, and even though there's a RAMCA strategy, this strategy has not really been fully implemented, and integration has not been fully realized. We would like to publish data from studies conducted, maybe follow up on the work that was done with the University of Antwerp in 2008, and carry on with some support from partners to make sure that we do more studies. Currently, we're working closely with the Botswana-Harvard partnership, but we would encourage to have more partners to work with the country. We would like to secure funding for the immunization program, including the hepatitis antigens, and we would like to strengthen the immunization, the EPI program in country, especially to see where the hiccups are in the health system and how we can really get our coverages back to the 90% that we used to enjoy. We are looking actively for funding to print new MCI guidelines, and also get technical assistance to make sure that these guidelines are updated and are current. We need support from partners to make sure that they're relevant to the elimination targets that have been set globally. And lastly, we need additional resources, human resources, and as well as financial for triple elimination to be realized. And one of the main pains that we experienced is that our domiciliary support visits that were used to be done by midwives are also not being done. And we would like to strengthen community midwifery and maybe have focal persons assigned to do such work. This slide will compile with the contribution of the maternal and newborn program, Jessica Mafasizwalo, and the MNE focal person there, Mr. Modise, and the EPI manager, Maria Subaging, and my co-presenter, Mabusang, and the PMTCT HIV program manager, Majindwa. So thank you for your attention. I thank you.